My name is Ben Rogers, and this year I'm going to be talking to you guys about the esophageal. It was nice of Helen, I guess, to call it esophageal topics, which I guess gives me free reign to talk about literally anything I want, anytime. So I'm going to talk to you guys about things like esophageal motility, reflux, Barrett's esophagus, I hope, if I have enough space, and esophageal adenocarcinoma will be in there too. So I look forward to it. As you guys heard, I really would love to be interrupted. If you guys have any questions, if I'm talking too fast, if this is too off topic or whatever, you guys can tell me and we can back up. And I would love to make sure that everybody feels happy about esophageal disorders, at least at a perfunctory level. The other thing is that you know, everyone who comes to my clinic thinks that there's some sort of magical treatment, and they want to hear about how to manage patients with reflux. I think that that's the least important part of it. You guys already know them. You guys are. I mean, my mom can dose a PPI, so I don't focus on that, and that's for a very specific reason. I think that the most important parts of managing people with reflux are just identifying who the patient is. Meaning that, you know, is this somebody who actually has true reflux, or is this somebody masquerading? And so we're going to get into that a little bit. All right. So you guys have general clinic, right? So you guys have a general internal medicine clinic. And so, I mean, I hope that by the end of this that you have an idea of at least where the management should go with patients, and that part can be very clear. Let me say let me back up. The evaluation of these patients should be, and if that part's very clear, then I'll feel very happy. So we all know where to start, and I guess the first question is, do we even have a problem with reflux? And you say, if we have PPIs, then who cares about reflux at all, because PPIs are all I'm going to give. And again, I said that to a certain extent, that's very true. You know, the PPI has changed the game a lot. And, you know, the question is, if I give a PPI to everyone, how many people are going to respond? Because I do think that there is this supposition that if you give PPI to someone, that they should just get better and never come back to your clinic if they have reflux. And as you will or have already learned, that's not the case. We know that people with erosive esophagitis, meaning definitive LA esophagitis, and we'll talk about what that means here in a minute, you know, if we see that those people respond really well, or if they have ambulatory reflux monitoring that's abnormal, that those patients do respond in a pretty favorable manner. You know, 3/4, you know, 4/5 of them are going to do well, which is helpful, that's nice. But the problem is that if you're dealing with some of these people who don't have true GERD and you've given them a PPI, then you've basically got a 50-50 shot. And you can see how if you keep giving PPIs, more PPIs, or changing the PPI, or trying to give Gaviscon to someone who actually doesn't have reflux disease, even though they have the symptoms, that's going to become an annoyance in your clinic very quickly for both you and the patient. And so the question is, do I even start with a PPI? And I hope that most of you will take a step back and say, well, of course, you always start with a PPI. That's what we do, and so that's the way it is. The problem is that we know that, or we should know, that whether or not you actually give medications up front is going to depend on the person that you're dealing with. And so I think that this is something that gets harped on a lot, and so I'll harp on it a little bit more. You have to think about the person in front of you, and you have to decide what it is that they're saying to you, and whether or not it's something that is at high risk for even being reflux to begin with. And this happens to you guys a lot. So you get patients who say, I have reflux because I have this, okay, because the internet says so, or because my dentist told me that my teeth are eroding, or because I have a cough and the palm people can't figure it out, or because the ENT people say I have allergies, or name it. It's all, I mean, it gets blamed on reflux. And so the reality is that if you become a gastroenterologist, true, but even if you don't become a gastroenterologist, you will have to deal with this in your clinic. And so the problem is that the response is completely different for someone who has a typical versus, now this is to medications, this is to PPI. The response to medications is completely different for somebody who has typical symptoms versus atypical symptoms. And so let's talk about what that means. Everyone always comes to you and they say GERD. Everyone, I can't tell you that, even in my own clinic, people come to me and they say, I have acid reflux. And I say, well, you have heartburn. And they're like, no, I mean, I have acid reflux. I know I do. This is what it is for sure. I mean, my mom told me so. And so trying to figure out whether or not, they have symptoms in response to acid reflux is the challenge that we're talking about. And so the number needed to treat really matters here. So, Helen, am I allowed to pick on people? Or? The good thing about my picking on any of you is that there's no way you actually know the answer. It just is a way for me to have fun with this or whatever. I mean, there is no way you do not know the number needed to treat for these, but it's fun for me to make you guys think about it in a little. So Helen, what's the number needed to treat for PPI, for heartburn or regurgitation? A range is fine. This is obviously going to be a guess. That's a really good guess. So for heartburn, it's about 4. For chest pain, it's probably about 6 or 7, and then for regurgitation, it's probably about 8. Okay, so those are the number needed to treat. So if you have hoarseness or cough, I wish I knew anyone. I don't know anyone else's name, so we're just going to start this way. Number needed to treat for cough.
With PPI?
PPI.
10.
Okay, we'll ask the whole section. This is like Price is Right. He just gave that's like $1. He bet $1. 48? 8. You went lower.
Lower the 50 cents.
I like it. 50 cents. I like it.
25.
Okay, all right.
11.
Now we're cooking. All right, we went the other way. 90. Okay, so in order to treat somebody with PPI effectively who has these atypical symptoms, you've got to go way up. So if someone says to you, I have hoarseness or whatever it is, you've got to think, now I'm not saying that they don't have hypersensitivity to reflux. I'm not saying that reflux isn't changing their mucosal lining, that any of these things aren't possible. What I'm telling you is that that's not going to be an effective treatment for the vast majority of your patients. So you better think about something else. The other thing is, all right, so let's keep going then. What percentage of people, if you just take people off the street and you have an otolaryngologist, look at them and decide whether or not they have findings consistent with reflux. Yeah, 4 feet, don't tell I said this. But so what percentage of people, and I think we're down here, what percentage of people will have an abnormal finding just by the scope from them? Oh yeah. No. Whichever. That's fine. We'll go that way.
I would say 20 people.
Okay. All right. You got to get aggressive with these numbers. All right. 92. So 92%. So the problem is, and in fact, I was without symptoms. I was in my primary care physician's office, and he was checking me out, and he said, the back of your throat's a little red. I think you have reflux. And it's like, maybe, I guess, okay, like, are you going to give me a PPI, which they do work. But anyway, but the point is that these things are very nonspecific. So you have to think about who it is that you're dealing with. So if you have heartburn or regurgitation, it's 8 weeks, okay? So chest pain, it used to be this thing, and this is about to be updated. So a lot of this comes from the Lyon consensus, okay? So this is a document that was first published in 2016, and they're about to update it. It's not released, so this is still current, but in about 2, maybe less, a month or 2, this is not going to be current anymore. So you used to have to think about chest pain a little bit differently, but now chest pain is going to be lumped with the others because it does respond to PPI. So you have to make sure it's not, the heart is more important, let's be honest. So you have to make sure it's not the heart. But once it's not the heart, you can go ahead and start looking into this. So you give them a PPI. Okay, so now you've got atypical, and then we say upfront testing. So what does upfront testing even mean? Okay, upfront testing is ambulatory reflux monitoring, which is a wireless or a wire-based pH monitor or pH impedance combined monitoring. And we'll talk about what that means in a second. But now you've got this person in clinic. So now let's rewind a little bit. Okay, so now what we've got here is you've got these groups of people. Okay, and actually, so now I even made it easier. So now you've only got 2. Is there a pointer?
It's something sort of.
Today's a not working day. Is it the one in the middle, right? The one that looks like it's supposed to be a light?
It's more often than not.
Yeah. So now we made it even easier. Now I'm going to tell you that side and this side, okay? Heartburn, regurgitation, chest pain is typical. Everything else is atypical. It's even easier. So now you're going to give them a PPI or test, okay? So now you've given someone a PPI, okay? And if they respond, it is very important to wean down. So this is outside the scope of the lecture, but keep in mind that no one needs a drug that they don't need, okay? PPIs are the same. The dementia thing is not real. The kidney failure, probably not real, okay? Osteoporosis, there seems to be an osteoporosis link. So if you've got, women of a certain age, you need to be thinking about, do you need to supplement? Can I get them off? Do they need this medication at all? And certainly, think about, how badly they need that medication. And then C. diff, the rates of increased hypomagnesemia is real. I'm just trying to rattle these off so that the in-service training exam scores, I think that's important here. So these things are real. The other things that they talk about, the dementia particularly, there was a big study that came out recently, the dementia, probably not real, okay? And also for you guys too, the important thing is don't give omeprazole and Plavix together, use one of the other agents. I think sometimes they ask that one too. You always want to be on the lowest dose of anything, right? That's any medications, that's PPIs. I will say, please, one of the things, and this is a clinical management thing, if you've got somebody who's 70 years old and the heartburn is debilitating and they can't go out with their friends and they're worried about dementia, please don't stop the PPI. I mean, there's been a rash recently of this stopping the PPI thing, and sometimes it's the healthy move and sometimes it's not. But as internal medicine providers, if that's what you guys do ultimately, definitively, then you have to be a little bit careful. Okay, so if they don't respond, then you scope, and then what defines abnormal? So this is the LA grades. I mean, you guys really should, in my opinion, know this. LA grade A on the top left, that's breaks less than 5 millimeters. On the top right, grade B, that is breaks greater than 5 millimeters, but don't cross folds. Grade C is they cross the folds, and you can see there's a pictorial representation of what the folds look like, right? So they cross folds, but not more than 75%, and there's grade D. The reason that matters is that up to 15% of people, if you just go out on the street, somewhere between 7 and 15% of people, at least in a Nordic sample, had grade A esophagitis. So we're not sure what grade A esophagitis means. So that's not definitive. And so if they have grade A esophagitis, you can't just say, oh, this person has reflux. That's not the case necessarily. The reason we do this is because we want to know who's going to respond to advanced therapy, meaning if the person's not doing well with medications, you want to be able to say that they have reflux or do not have reflux for sure. And if they don't have reflux for sure, then you might have to go a different route here. Okay, Barrett's esophagus is long segments. Long segment is 3 centimeters. Okay, so anything less than that is not definitive enough for taking them to the next stage in therapy, okay? It's not that if they have Barrett's esophagus, they don't have reflux, they do. These are people who are going to respond to, this is now management, okay? So you're thinking about who is going to respond to something more aggressive, and we'll talk about what that means in a little bit. But in order to say that this person has definitive reflux, they need more aggressive management, you have to do a little more testing if they don't have at least long segment Barrett's, okay? That's what Barrett's esophagus looks like, you know that. And if it's normal, then you're still going to have to do testing, okay? So what is testing? So again, I promised that I would show these pictures. So this is either in the diagram it says pH monitoring, but this is what it looks like if it's pH impedance as well. So what we do is we dangle a catheter down the nose. It sits down there for 24 hours, and we monitor with pH only. Obviously, you get pH only. With pH impedance, you get impedance monitoring. I'm going to show you what that means. But the idea is that you get an idea of whether or not they have reflux. The reason that matters, here's another good number. So we'll go to pink shirt here. What percentage of people, if you scope them on a PPI, are going to have erosive esophagitis? Symptomatic people, erosive esophagitis. 10%, not a bad guess. So we'll move over. If you scope them off PPI, what percentage? Symptomatic people, you scope them off PPI, how many of them will have erosive esophagitis? 30%. So it's 10%, 30%. You guys did very well splitting the difference there. So And again, that's the other thing for you guys coming in. The reason these are fun is because there's no reason to know this. Actually, some of my other favorite numbers is that if you just ask a gastroenterologist, does this person have GERD, and then test them, Stuart, I do know. What percentage of people who a gastroenterologist thinks have GERD will ultimately be found to have definitive GERD?
50%.
Not bad. I like where you're going there. It's probably more like 65 or 70%, something like that. So the reality is you can't even trust your own opinion, which is exactly why I like these numbers. Like these numbers, like there's no way to know this, but also it's just kind of revealing of the, we don't have a concept of these sorts of things. So anyway, testing, and then this is a wireless capsule. This is called the Bravo. So what I do is during endoscopy, I go in, this little thing sucks some of the mucosa into the channel, you drop a pin and it stays down there 6 centimeters above the squamous junction some people do 48 hours. I think that we should do 96 hours usually, and the reason for that is in the new Lyon consensus, they're going to say that 2 days or more on a 4 days is a positive Bravo, okay? Because you can have normal and then abnormal, right? I mean, it makes sense that we know that certain factors will bring about reflux. And so it does matter, these day-to-day variations are true. What if you miss them? What if they stop eating? I mean, there's long been these concerns, and actually one of the surgery attendings told me that 40 years ago they had people either drink alcohol or not drink alcohol, and that changed the way people had reflux. So there are these little things that modify the test, and so you have to, the longer the better in my book. And so for you guys, the on or off therapy debate isn't that so much of a thing. I mean, really, you guys just need to know that some people are tested on and some people are tested off therapy. The only thing to keep in mind is, and there's no way this will come up on the in-service training exam, but most people, the vast majority, should be tested off PPI therapy. The reason for that is that we don't have great data for people tested on therapy, so it's hard to predict outcomes. So it's just a logistical issue. If you don't know who's going to respond and how, then you shouldn't test people that way because we don't have data. Now, this is important though. If you're going to do this, if you do pH therapy only, then you should be off of a PPI so you can see how much pH there is, because that's all you're going on. So you want to know how bad it can get. Okay, so we've got some of the features here of the difference, the different features between the two. With the wireless, you can do prolonged. No one wants a catheter down their nose for 96 hours, obviously. Obviously, the wireless is more comfortable. Most people don't even feel it. The pH impedance will detect non-acid events, and I'm going to talk about that in a second. And then, so I can also get non-reflux diagnoses. For you guys, that's supragastric belching or rumination syndrome. I can see those on this test. The cost is higher for the wireless monitoring. And then you have, of course, you'll see here in a second why, but the wireless monitoring is much easier to interpret. The computer does it for you. And really the metrics that you're going to get out of this, and we're again going to go over this in just a second, but the acid exposure times and the Meester score, okay? So this is what it looks like on my end, okay? This is, we'll continue the fun here. So if you have, does electricity pass quicker through air or water? Water. So the idea is that this is a measure of impedance. So this is actually ohms. So what you see is that the line, hopefully you can appreciate it here, the line goes down. And the idea is that if the line's going down, impedance is going down, which means that there's water. And that's the whole crux, that's the crux of the whole thing. So you can see here, the line goes up. And so that would be, to continue, air. So the idea is that I can see air, I can see belches, I can see when you're swallowing, I can see, the directionality of these things tells me what's going on and when. And I think that, yeah. See, so you can tell on the left-hand panel, you can see that the impedance is dropping and that it's dropping from top to bottom. Hopefully you can tell that the orange one, it happens before the bottom orange, red. And so that is a swallow going from the top of the esophagus to the bottom of the esophagus, okay? The top two channels are up here, the bottom four channels are down here. So the top is the top and the bottom is the bottom, okay? And so you can see down in the second panel that, I really wish this thing would work. So you can see in the second panel that it starts at the bottom and then kind of works its way up, and you actually see a swallow coming down, so that's a reflux episode. And this bit is actually the pH dropping. So this is impedance, this is pH. So you can see that the pH didn't drop here because that's a swallow, that's bringing stuff down. This is bringing stuff upward, and you can see the pH drops. And then here, you can see that this one goes back the same way, pH drops, that's liquid, and you can see that the pH didn't drop, so that's a non-acid event. The interesting thing there is that could also be, does anyone want to take a stab at what the thing on the right could also be? This is way above your, if you do this, I would be forced to buy you a cookie. So the idea is that I can't tell whether this is volitional or this is something that's physiologically happening on its own, which is to say that if you've got a patient with rumination, meaning they eat and then shortly after they eat, the stuff starts coming back up, I can't tell if their patient is doing this on purpose. So we have cutoffs for this so that we know that if this happens a lot, it's probably rumination, because really a certain number of reflux episodes right after you eat is just not going to happen. So anyway, so this is what it looks like on my end. This is what a pH-only test looks like. The bottom is the gastric. You can tell that the pH is below, this line is 4, pH of 4. And the only reason that matters is you can tell that the pH in the stomach is almost always below 4, whereas the pH in the esophagus only dips down intermittently. You can see how it dips down intermittently below pH of 4. Any questions? I know, it's riveting. So this is what it looks like when you get it back, okay? The things that matter most are acid exposure time, and for outcomes, Demeester score. Most gastroenterologists don't want to talk about the Demeester score. It was created by a surgeon, but it really does predict outcomes, mostly because the Demeester score, in large part, is predicated upon the acid exposure time, but again, outside the talk. So then you have, so now what you've got is a situation where, let me see if did I not get into this with, I didn't do the slide. So this will be the hardest thing to follow, okay? You have now a situation where you have an individual who's been tested with endoscopy. They didn't have anything. If they had something, you don't need this, right? So you've got erosive reflux disease. That's one diagnosis. The other 3 diagnoses in GERD are going to come from this, okay? This testing here. So if you have elevated acid exposure time, which you don't have to worry about, but if it's over 6% per day acid exposure time, that's abnormal, okay? So if you have elevated acid exposure time, that's non-erosive reflux disease, okay? Non-erosive reflux disease. If you don't have elevated acid exposure time, okay, or a couple of other things mixed in, hiatus hernia, reflex episode numbers, that doesn't matter, put that out of your head. Then we also have the computer will calculate how many times you have symptoms, heartburn, over the study period, and it will calculate the probability that there is a true relationship between reflux events in your esophagus and your symptoms. And that's called the symptom association probability, okay? So if you have a true relationship with the symptoms and the reflux on this test, that's called reflux hypersensitivity if there's no pathologic acid exposure. And if there's nothing, no relationship between symptoms and normal acid exposure, we call that's called functional heartburn. I think the term functional is falling out of favor, and I don't know what the next iteration of Rome is going to do, but they're taking functional, the word functional, out of a lot of diagnoses, and I can only assume that they're going to do the same thing here. Okay. So anyway, so those are your diagnoses: erosive reflux disease, non-erosive reflux disease, reflux hypersensitivity, functional heartburn. And if you think about it, the last 3 have relied upon this. And so if you're going to decide, you would have to use something like this. And hopefully you can appreciate now that the reason we've spent so much time talking about this, or at least to me, part of the reason we spent so much time talking about this is that if you don't have that stuff, if you haven't done upfront testing, if you haven't done testing when you can't figure out what's going on, the reason we tell you to do that stuff is that it's actually time and cost saving to just go ahead and test the patient and find out what's actually going on, rather than continuing to do, BID PPI, and then trying 6 different, PPIs and all this sort of stuff. It's better to just test them and find out what's going on and get them what they need. And we'll talk about what that is here in a second. But, you really want to use this to your advantage to figure out exactly what's happening with the patient. Okay, and so now the question is sort of, or it becomes ultimately, if you think about reflux enough, is what are the predisposing things to to actually generating reflux. And part of this is because I think that some of this will come up on the in-service training exam, although to be honest, probably not a ton of it. But anyway, that we have these metrics where we decide how strong the lower esophageal sphincter is by this is a high resolution manometry image, again, way outside the scope. And so we've tried to figure out these metrics that can predict reflux. And so this EGJCI, where we calculate basically the strength of the crural diaphragm and lower esophageal sphincter, the complex, which is the esophagogastric junction. We try to figure out if that complex is intact, and if it is, there's some association. There was a thought for a little while that if that's really weak, that they're going to have more reflux. To be honest, that really hasn't panned out. The biggest thing in my mind, and this has been shown a lot and repeatedly and reliably, the biggest thing that predisposes an individual to reflux are things that increase abdominal pressure, like obesity, central obesity, but also the change in morphology. And so, all right, let's continue the percentages. I think the next in line would be, we missed a lot of people, but the problem is I know Harsh's name. So what percentage of the reflux barrier is the crural diaphragm versus the lower esophageal sphincter? These are fun for me because you can't know, Harsh.
I have no clue.
Of course, that's why it's fun. No one knows.
You may guess the number.
Yeah.
25.
Ooh, still low numbers. Yes. Yeah.
35.
It might be as much as 80%. So the problem is everyone thinks the lower esophageal sphincter is doing something. It stinks, and as far as we can tell, really one of the major barriers to reflux. And these numbers are. And the other thing, Harsh, is that this isn't an exact science. Okay, I mean I'm giving you these ranges based on, and I mean some of this data is from possum physiology studies from the 70s. You know what I mean? Like it's not perfect. Okay, they've done some three-dimensional high-resolution manometry stuff and calculated it, but I mean this isn't exact anyway, right? But the point is the crural diaphragm plays a big role. And so if you have a disruption, a separation, a hiatus hernia by definition is where you get a separation of the crura and the lower esophageal sphincter, then what you've got is a pocket of acid above that biggest barrier to acid. So the longer you get of Barrett's, the more acid you get, the more exposure you have, the higher acid exposure times you get, higher risk of Barrett's, all this stuff. It's very well delineated, and in fact, it's going to increase your risk of esophageal adenocarcinoma. So a hiatus hernia is a problem. And these are the different types of morphology, which I'm not going to harp on. But you can see that the percentage of abnormal, which is the pink, sorry, it's miscoded, but the high percentage of abnormal acid exposure times just flips, So it goes from mostly normal with normal to mostly abnormal with a larger hiatus hernia. And then the other thing is what you guys might expect, which is that, and this is a complicated diagram to just say that if you have poor squeeze in your esophagus, you have more reflux. You have to clear it some way or another, and so that is true. If you have absent contractility, meaning your esophagus doesn't squeeze, you're going to have higher acid exposure times. It's just a natural consequence. What's interesting too, and again outside the scope of the talk, is that what oftentimes with large hiatus hernias, we see people who have poor contractility, and it's a chicken or the egg sort of situation. Do they have poor contractility and so they don't clear, or do you have changes in the function of the esophagus in a response to long-term reflux? And so we don't know this, but we do know that you need that squeeze in order to get that stuff out. And this is something that comes up for us. The vast majority of people, so the reason this matters too is that, and if you ever order a pH impedance study from any center in the entire country, they have to do a manometry because they identify the lower esophageal sphincter on manometry. And so you're going to get a manometry too. The most important thing, because they do ask this occasionally, I think, is that the most common finding on manometry in GERD is normal. So it's completely fine to have a normal manometry. That doesn't mean you don't have GERD. Okay, and now here's the one that everyone sort of wants me to get to. Everyone wants to know then how to manage patients, okay? And I'll let you guys stare at this, but the problem is that this is actually how I do it. I will do everything I can, and we have here at Louisville something which I think is nice, and it's not unique, but it's not common. We have this thing called the Reflux, Swallowing, and Hernia Center, and I work very closely with the surgeons there, and it's one of the more enjoyable parts of my job, honestly. But I think that one of the things we agree upon is that if you don't select the right patients to surgery, it's going to make everybody's life miserable. And the surgeons are very good at identifying people who are at high risk of not doing well, because that's not going away. If you create a problem for somebody, meaning they don't have reflux, and you try to treat reflux and you give them a surgery and it turns out they had achalasia or something, heaven forbid, then that's a problem that's not going away anytime soon. And so anyway, so this is the way I do things. They come in, I really do try to talk to people about what they're eating and how, and especially if they have symptoms late at night, have them elevate the head of their bed, no late night eating, no alcohol, no chocolate. Are you drinking, 2 jugs of coffee every morning? These things are true, and they're going to increase your, I forgot to ask. This one's also we'll go straight to the front of the room here. So what is the major mechanism of reflux? No way for you to know this. It's called transient, does anyone know? Transient lower esophageal sphincter relaxations. For you guys in internal medicine, I don't think they're going to ask that, but if you do GI in the future, they're going to ask it. They ask it on every in-service training exam, but it is important. The thing to keep in mind is that everyone refluxes. Okay, we all have reflux. So there's no such thing. I've never seen a single PhD study ever, and I've read thousands, that don't have any reflux. Okay, unless you have, even for people with achalasia, eventually something finds its way in there. So the reality is that reflux is a part of life. It's whether or not it's pathologic, whether or not it causes symptoms, which is another big problem with esophageal adenocarcinoma. We know that those people had to have reflux in order to have esophageal adenocarcinoma. 40% of them won't have symptoms. And hopefully we'll talk about that later, but this is a big problem. But the point is that, everyone has transient lower esophageal sphincter relaxations. Everyone has reflux. The question is, how do we reduce the incidence, and how do we keep it from being so bothersome? And the way we do that is by, trying to keep if you think about it, if you have increased abdominal pressure from central adiposity, then, when that TLSR happens, things are going to come up. Sleeve patients is the same thing. That's a refluxogenic procedure. Sleeve generates some pressure there. We have a paper about this. It's probably proximal, stomach pressurization in people who are abnormal. And so it's an actual pressure phenomenon. The TLSR opens up, acid comes through. So you either neutralize the acid, and there is a conversation about whether bile is involved and what you do in that situation. But in general, we treat acid. And so you either reduce the acid or you modify things that will cause TLSRs, caffeine, chocolate, alcohol. These things, they're known to do that. And so the mainstay of helping that is exercise. Don't eat late at night. These lifestyle things, again, I go back to it again. Alginates are very good. In my opinion, we should be giving everyone alginates. Alginates are what that you think they are. It's algae. And it does the same thing in people, potentially, this is what we think. It does the same thing to people that it does out in the pond. It just floats along that stuff in the stomach and keeps it from coming back up. Okay? The reason I like alginates, it's Gaviscon with alginates usually. The reason I like it is it's, as far as I can tell, almost no side effect, so why not? And some people do very, very well, and for people who don't do well, they've lost $15 on Amazon. It's not a prescription, you have to get it online, but I've had some patients do very, very well. Again, not everyone, but it's like exercise. Who's not going to benefit from exercise? Anyway, so if they haven't done well in a proton pump inhibitor or an H2 receptor antagonist, which H2 receptor antagonists are inferior to PPIs, we know that as well. But for the management of symptoms overall, that's the caveat I would say. For some things they're just fine and you can try them. But anyway, so if they don't do well with the PPI, so now you're going from standard management to GERD confirmation using investigation. Okay, then to advanced management. And what I would say at that point is that that's where you guys should leave off and refer to me. I don't, or a surgeon or someone that you trust to do this management to figure out what's going on. Because the surgical managements at that point, again, I mean, really should be tailored. They should have certain studies done. Really you should have a manometry up front and maybe a barium esophagram. Some people advocate for those on everyone. But then what they do is that they do either, so looking at the advanced stuff here, you can see they do fundoplication or magnetic sphincter augmentation or Roux-en-Y gastric bypass. And so fundoplication, they can do partials or fulls. And then what they do is they take the stomach and just wrap it around itself. The magnetic sphincter augmentation is a bracelet of magnets, literally. And what they do is they expand and contract. They expand to let stuff through, but then they contract back down. And hopefully the force of the reflex aid is not enough to open that back up and come through. And then you've got Roux-en-Y gastric bypass, which I do preferentially for all people who are BMI over 35 and have pathologic reflux. And then you've got some of the other things like esophageal incisionless fundoplication. Radiofrequency ablations are for Barrett's, and injection of bulking agents are not something that I would recommend. That should only be done in a research setting. Some of these things, if at all. And then so you've got the TIF, the transesophageal incisionless fundoplication, which is where they go in and endoscopically do what a fundoplication does. They pull in some of the stomach and they go all the way around and staple it together, and it creates this barrier to reflux. And then electrical stimulation of the lower esophageal sphincter is something that's been written about, but is not being done very often, or here not at all. So that's sort of an experiment. You've got some of these things that are experimental, as you always will, and probably should have. But and then it's not on here, but we do have the potassium competitive acid blockers that are coming down the pipeline, which it's being played out right now in the literature. They've been approved in Japan for 10 years or so. Some of the literature is coming out of South Korea. I think that they'll be FDA approved. They should have already been approved potentially, but that's a long story that I'm happy to talk about, offline. But the moral is I think the PCABs are going to be approved, and that will be another agent for people. Technically, if someone responds to PPI, you can switch them within class. Meaning, if they don't do well with omeprazole, that you can try pantoprazole. I usually don't go that direction. I usually go to rabeprazole, which many of you may not have heard of. The reason I go to rabeprazole is that there are about 5% of people have CYP mutations where they are rapid metabolizers of PPI. Rabeprazole is processed by a different enzyme, or maybe through the kidneys, but it bypasses the CYP. And so some people advocate for genetic testing. I don't do that. I just switch them to rabeprazole and see if they respond, and if they do, then I got lucky. So you can try rabeprazole for that reason if you want. I do that a lot. Insurance sometimes won't pay. I went through it as quick as I could. Are there any questions or burning desires to know about reflux? I got a couple, I think you're first.
Once you got symptomatic control on people with PPIs, do you try to wean people with H2 blockers? Do you try to just wean them totally off? What's your strategy knowing the side effects of PPIs?
Yeah, again, it's tailored. So, I mean, if you've got somebody who's got Barrett's esophagus and symptoms and a PPI is controlling it, I mean, that's somebody who needs a PPI because you're trying to prevent that from progressing, right? So that's a way different situation than somebody who is, say, a 35-year-old woman who's already been taking PPI for 10 years, and it's providing marginal control. And you're like, it's like there's a family history of osteoporosis or something like that. I mean, it sounds trite, but I mean, I really do try to tailor it. The answer, online is lowest dose possible always on everybody. But it depends on who it is. I mean, some people, their symptoms are debilitating, not a ton, but that does happen sometimes. And so I've had several people like that where they come in and they say, I was fine on the PPI, but I was having these concerns for my primary care provider, and so, we'll have a conversation, and oftentimes I will just restart, and you can do a DEXA and find out how much risk they are, and there's a thought that it decreases absorption of calcium, right? And so my understanding from the limited amount of literature we have is that you can supplement that. So if it's something like that, for example, that's a lot different. But yeah, I mean, I do try to get people down. I try to remind myself to get people down lowest dose. I often will not switch to a H2 receptor antagonist unless they've had benefit from that previously. I you know, I don't think they work as well.
What were you saying about dementia use and PPIs? You shouldn't take people with dementia off of PPIs, but should you start them on it?
There's no relationship between dementia and PPI. Like giving someone a PPI does not increase their risk of developing dementia, in as far as we can tell. So if you've got somebody who's got rip-roaring heartburn and they've got dementia, then I probably wouldn't think twice.
Were some studies implying that there was a connection?
How many years ago was this? There was this huge manuscript, a series of manuscripts when I was in fellowship, that linked PPIs to everything. I mean, everything. Renal disease, dementia, osteoporosis, diarrheal illnesses, malignancy. I mean, whatever you could think of, really. It felt like to me there for a while, it was like whatever you could think of was because of the PPI. And for the last 5 or 6 years, they've been kind of, they had to dig down. There are a lot of articles about this. I mean, you can go hunting for this, and there's a lot of literature. It'd take me forever to review, but the point is that over the past, half decade, they've kind of gone back and done longitudinal studies, and we've learned that, some of the risks were overblown. Dementia was one of those things where it doesn't seem the relationship was true. The confidence intervals on some of those studies were like, 1.2, 1.3, which is really not great. The odds ratio were 1.2, 1.3. The odds ratio for lung cancer and smoking is like 10, right? The odds ratio for, I don't know. I mean, the odds ratios for real disease is supposed to be of like 3 and up is where you say this is probably a true relationship, and these were like 1.2, 1.3. And this was 90,000 people, really not well controlled for disease, past medical history and the other comorbidities and stuff like that, in a lot of gastroenterologists' mind. Now, every medication has a side effect. No person individually is immune to that. You have to be careful and get everyone the lowest dose. All these things are true, but the original work that was done probably overestimated the risk of these things.
What is acid manipulation on the chart?
Didn't hear it.
What is acid manipulation on this chart?
So the idea here is that there are certain things that, so for example, there's this thing called the left device, okay? So if you lay on your left side, you have fewer reflux events, which is actually counterintuitive to me. But I haven't had anyone actually buy it, but this thing buzzes when you sleep on your right side. So you can try to, or you can raise the head of the bed. There are certain things that we think can affect how much reflux gets into your esophagus, and especially at nighttime, So, that part's true. We know that if you spend more time on the left side at night, that you can reduce reflux events and acid exposure times and stuff like that. So you can try to manipulate the amount of acid that can see your esophagus.
Can you go over the timeline for when you would escalate towards from being on a proton pump inhibitor to now let's do surgery? How much time do you give?
That's pretty slow. The time to do testing for me is pretty quick. I mean, I'm always in favor of more data points. I try not to do things that you can't undo very quickly. I have long conversations. It's a tough one. But I'll test somebody just like that. I mean, I don't like waiting around. By the time they say, honestly though, I mean, part of it's my clinic. By the time I've seen them, they've often seen like 4 other people, and it's like, all right, But I don't like wasting time. So I'll give them a couple. If they come in, if I've given them a BID PPI, they don't respond. Sometimes I'll try rabeprazole if I've got high risk, or if they've got a hernia or something like that. I'm going to test you. I'm going to prove it's real, especially if you have a hernia. But I don't wait. You're supposed to give them 8 to 12 weeks on the PPI to see if it'll respond. Okay.
Sorry to cover this stuff out, but is there a particular amount of time, like do people with acid reflux, even with symptomatic improvement on PPI,
ever like deserve like a screening EGD to look? And
Oh, yeah.
how long? Like, you know, they have symptomatic improvement or escalating.
The ASGE lays out who to screen regardless, and it's mostly for cancer if you think about it. So you know, you don't want somebody who's had longstanding reflux to develop cancer without, you know, under certain circumstances. The ASGE, the ACG, and the AGA have slightly different guidelines, but it basically amounts to if you're over 50, if you're a man, symptoms for more than like 10 years. If you're the people who develop esophageal adenocarcinoma are white, obese men. So you know, then you've got a spectrum of risk, you know, and so and that's sort of like codified in those, you know, who to scope or whatever. But if I've got a young person who's responsible to a PPI, then you know, family history. But if they're not responding, then I take a look. That's if you don't respond, and that's the thing. It's the same thing I tell the GI fellows. If you've got blood, I don't even think about it. A little bit, lot, I don't care. I'm going to take a look. You know, and so if you've got symptoms, I mean, I'm not going to keep scoping. I'm not going to repeatedly scope you and think that things are changing. I'm just going to take a look. Is there something really egregiously wrong here or not? And if there's not, then you're done. You know, that's sort of the way I play that. But if you're not really responding as much as we want, then I'll take a look.
Would it be, I'm just trying to think like from a PCP perspective and trying to simplify things when you have 1,000 things going on. Do you have like someone that you're sending for their screening colonoscopy?
If you think about it, just send them to me.
Just give them an EGD.
Yeah. If you're thinking about it, if you're worried about it, yeah. I would scope everyone in this room happily. Maybe after this lecture, I'm going to end up scoping a couple of people. I mean, it's propofol. You're talking about propofol, and I mean, it sounds, well, it's tough for me. From a global standpoint, you don't want to scope everyone in the country, and you can't. On an individual level, I wish I could scope everyone in the country. We do know that having a scope reduces your risk of having esophageal adenocarcinoma in the future. Now you have these intervals, you have these people who get away, but at least I tried. And again, I come down to the fact, I asked myself, would I scope a family member for very little? And I mean, there's this like grade, right, where it's like you really have to think about it for some things, but a scope, I mean, I don't know. I mean, I'd scope my mom every Monday. I don't, you know, I mean, it doesn't. So I mean, you know, and you guys have done it. I mean, if you guys do gastroenterology, you know, my parents were like, oh, I don't have any symptoms. And what did I do? I mean, I was going to physically drag them to the thing if I had to, because that's the best we've got. Is it perfect? No, it's the best we've got.
Just at the moment, the Bravo reading you showed have this, but how often do patient-reported symptoms during a Bravo actually coincide with significant findings or changes? Is there any accuracy or significant correlation between patients saying, oh, I feel reflux right now, and then actually having it?
Well, that's what defines reflux hypersensitivity. The relationship has to be within 2 minutes of the event, and if you say that it's within 2 minutes, then that's a real, we just arbitrarily said within 2 minutes is real. And if it's real, then it's real. And so we say there's a relationship between symptoms and events. And if that's the case, then we call it reflux hypersensitivity. But you do have to look at what it is. You have to ask yourself, is this really a reflux event, or could this be something else? Is the person just drinking orange juice? And so, I mean, you do have to pay attention to sort of what's going on with the patient and meal times and all this sort of other stuff, but that's what we do. We say, we assume that, but if they click the button like crazy, then there's not going to be a true relationship, because there's going to be a million. So you can't actually like cheat it by clicking it a bunch, because then it's definitely not going to be positive. And it's going to say, well, you had a million that weren't related to anything at all. So that would be negative. So you can't really manipulate it that way. And I know that's not your question probably, but you have what percentage of people who have one have a positive symptom association probability? I don't know. That's institution dependent, I'm sure, but plenty of people have nothing, like don't have any relationship. Sloan, do we approve? Are we done? Sloan says we're good.